Next lecture, inshallah, will be about the external organs and the perineum. So let's start by the uterus. Uterus is a muscular organ, right? And that uterus that at one point was able to hold you is very small in terms of measurements. It's only 1 by 2 by 3 inches, meaning that it is 3 inches in length, 3 inches, 7.5 centimeters, like this, and 2 inches in width and 1 inch in length. So basically the size of the uterus is like this before delivery or before conception, before pregnancy, right? So it's a very small structure, muscular organ that you're going to see in the lab, located between what? Between this, what is that? That is the bladder. What do we have anterior to the bladder? Pubic symphysis. So it is between the bladder and between the rectum. So it is very small in size, 1 by 2 by 3 inches, 3 inches in length, 2 inches in width. And the thickness is only 1 inch. So the uterus actually has different parts. The upper part is called the fundus, and then we have the body. The body, when it narrows down, we call it the isthmus, and then the last 1/3 is the cervix. So the cervix is not a separate organ. It's only the last part of the uterus, the last inch. The cervix is about 2.5 centimeters. Okay? So to have a better view, if we do, what kind of section is this? Coronal section. What is that? That is sagittal section, okay? So in coronal section, if we do a coronal section, we divide the organ into anterior and posterior, okay? You can see that this part here that has no cavity is the fundus, and it is above the entrance of the fallopian tubes. So the fundus of the uterus is that part of the uterus located above the entrance of the fallopian tube and has no cavity. Now this is the body, that's where the body narrows down to the isthmus, and that last part is the cervix. In a coronal section, if you look at the cavity of the uterus, it looks triangular. While in a sagittal section, that is the uterus, that is the bladder, this is the vagina. The uterus is merely or barely a little slit. The cavity is not that big. Okay, so this is the fundus, no cavity, that is the body, and the last 1 inch is the cervix of the uterus. Now, the cervix actually invaginates the anterior wall of the vagina. Vagina is like a tube. Okay, and the cervix will come and invaginate the anterior wall of the vagina. So we will have part of the cervix intravaginal inside the vagina, and we will have part that is supravaginal above the vagina. So this is the cervix, the last 1 inch of the uterus. It has 2 openings, one to communicate with the cavity of the uterus, the body, and one will open to the outside. So this is the internal os. Os is an opening, and this is the external os. Actually, this is the opening that you can see when you examine a female. You just use a speculum that will open up the vagina, and you can see actually the lips of the external os. And by looking at that, we can know if this is a parous or nulliparous female. Parous, female who delivered before, a female who delivered before. So it's going to be stretched. So we're going to see an anterior and posterior lips. It's going to look like more transverse or horizontal. While nulliparous, those who did not deliver before, they're going to look round. So basically, you use like speculum that opens the vagina, and you look at the external os like this, and you can see the opening of the cervix. So the cervix is the last part of the uterus. It invaginates the anterior wall of the vagina. So it has an intravaginal part and supravaginal part. It has two openings, one internal os and the external os that you can see by examination. Okay. Now, the uterus is covered by peritoneum. And if you still remember from the GI lectures, the peritoneum will come from the anterior abdominal wall onto the bladder, and at the level of the internal os is going to be reflected onto the uterus. Okay, so it's going to cover the uterus anteriorly, superiorly, posteriorly, and it's going to go even down to the upper part of the vagina. Here at the level of the internal os, here will go down to the level of vagina, and then it will going to be reflected onto the rectum. Okay, so the peritoneum will come from the anterior abdominal wall onto the bladder, onto the uterus, and from the uterus onto the rectum, creating the recto. What is that? What is this? Recto-uterine pouch, which is pouch of Douglas. What is special about pouch of Douglas? It is the lowest edge. Yeah, it's the lowest point of the peritoneal cavity when a patient is supine on their back. So that's why if any accumulation of fluid were to happen for any reason, it's going to mostly accumulate in the pouch of Douglas. Okay. Now, this is the uterus, and that is the rectum, and this is the pouch of Douglas. Okay. Now, that's why when we talk about the wall of the uterus, we say the outermost layer is the peritoneum. Okay, and then we have the muscle, and then we have the endothelial lining of the uterus. So we're going to call the endothelial lining as the endometrium, and this is the layer that sheds during menstruation. Okay, and then you have the muscular layer, myometrium, and then you have the peritoneal layer on the outside, which is the perimetrium. Okay, so the wall of the uterus, we have the perimetrium, myometrium, and then the endometrium. Now, attached to the superior angles of the uterus are the two fallopian tubes. Okay, these are the fallopian tubes. We have two of them attached to the superior angle of the uterus. Now, the fallopian tube is about 10 centimeters in length, and it has different parts. A main function of the fallopian tube is what? Pick up the ovum and provides site for fertilization and nutrition for the ovum and fertilized embryo. Okay, so this is the ovary. This is the ovarian ligament, and this is the fallopian tube, and clinicians, they refer to that as salpinx. Okay, now these are finger-like projections. We call them fimbriae. Okay, they're gonna pick up the ovum, and the ovum is gonna go to this part, which is the widest part of the fallopian tube, and that is called the ampulla. That's where fertilization occurs. So the sperm comes all the way from the vagina to the uterus, fallopian tube, and it's going to meet the ovum here in the ampulla, okay, which is the site of fertilization. So fimbria, infundibulum, ampulla, the widest part, and then it's going to narrow down as the isthmus, And then we have part that is running within the wall of the uterus that is called intramural or interstitial part. Okay, so if you see here, actually there is continuity between the cavity of the vagina, that is of the cervix, the uterus, fallopian tube, and then into the peritoneal cavity. So infection actually can spread from the vagina or the uterus to the peritoneal cavity. We don't have that link in males between the peritoneal cavity and the outside wall. Okay, so parts of the fallopian tube, fimbriae, finger-like projections that will be able to pick up the ovum, and then you have the the ampulla, which infundibulum, of course, and then the ampulla, the widest part, narrows down to the isthmus, and then we have within the wall the interstitial or intramural parts. Now, what supports the uterus and the ovaries and keep them in place? Actually, we have two things. Number one is the tone of levator ani. You know what levator ani is? What is levator ani? Muscles of what?
The cervical diaphragm.
Cervical diaphragm? Okay, pelvic diaphragm, right? It's mostly composed of two muscles, levator ani and coccygeus, right? So the tone of its pelvic floor, right? This is what prevents the organs from in the pelvis from going down. And also it provides support. So the support of levator ani muscles, but also we have the ligaments of the uterus. Ligaments of uterus are in three categories. Ligaments derived from the gubernaculum, and visceral pelvic fascia ligaments, and broad ligaments. And we're going to talk about those three categories of ligaments one by one. Now, ligaments derived from gubernaculum. What is gubernaculum? What is it? Any idea? No embryology lectures yet?
It's the cells that help the ovaries or and the embryology to pull down the testes of the ovaries.
Okay, so it is a band of mesenchyme that actually precedes the descent of the testicles or the ovaries before they are located in the abdomen, right? Testicles in the posterior abdominal wall, and then they will descend to the scrotum and they will pass through the inguinal ligament. Before they do that, they send a guide that will see if the pathway is open, no problems. That is called the gubernaculum. It's a band of mesenchyme that will precede the testicles before they descend down to the scrotum, okay? And then later on, this band of mesenchyme will disappear, okay? So testicles will reach the scrotum, and then the mesenchyme will disappear completely. Now, in case of females, what happens? Yes, we have a band of mesenchyme attached to the ovaries, and it's going to go from the ovaries all the way through the inguinal canal and to be attached to the female external genitalia, labia majora or labium majus. They don't have testicles, so instead it's going to go to labium majus. Now, in case of females, this band of mesenchyme or ligament will not disappear. It will remain. But what happens is that now this is the ovary, this is the band of mesenchyme, this is the ovary, this is the band of mesenchyme. Part of it will be attached to the uterus, and the second part will be between the uterus and the labium majus. So it's going to go down through the inguinal ligament to be attached to the labium majus, okay? So mesenchyme does not disappear, or gubernaculum does not disappear. It leaves two ligaments. One that attaches the ovary to the uterus, and the second one from the uterus to the labium majus going through the inguinal canal. Okay, so these are ligaments derived, taken from gubernaculum. Now, the second category of ligaments are the visceral pelvic fascia ligaments, or clinically they call them parametrial ligaments. What do we mean by visceral pelvic fascia? What is visceral pelvic fascia? We spoke about it in my first lecture. What is it? What is fascia? Huh?
A covering.
Covering. What is pelvis? What is visceral?
Connective tissue?
Type fascia. You don't know what fascia is?
Connective tissue?
So you've been here for 2 years, you don't know what fascia is? What separates between the pelvic organs and that provides kinds of cushion? Last lecture I said all pelvic organs or structures are expandable. You have the bladder, you have the uterus, right? You have the rectum. What separates between these structures when they expand? There is fascia, connective tissue, right? This fascia actually in the area of the pelvis becomes condensed. So it separates between the organs and then it's going to fuse down with the fascia covering the muscles. Each muscle is covered, is surrounded, is wrapped by fascia. So this fascia between these organs is going to be fused with the fascia covering the muscles of the pelvic floor and the pelvic walls. Okay, this is pelvic fascia. Now, in the area surrounding or close to the uterus, specifically in the area where the uterus joins the cervix, this fascia becomes condensed, becomes thick, like a ligament, and will form 3 ligaments. One of them is the transverse cervical ligament or cardinal or McEnroe ligament, which is here. Here, the uterus was sitting here, joining the cervix, and laterally between the uterocervical junction and the lateral pelvic wall, we have condensation of the fascia, becomes like a ligament. In this ligament, you will have the uterine blood vessels. So where do you find the uterine blood vessels? In the transverse cervical ligament, which is part of parametrial ligaments, the pelvic, visceral pelvic fascia. Now, why is this very important clinically? Not only because it supports the uterus, but also it contains the uterine blood vessels. So the first thing you do when you want to remove an organ, what do you do? Ligate blood vessels so they don't have bleeding. So if you were to ligate to remove the uterus, you have to ligate the uterine arteries, right? So where do you look for the uterine arteries? They are hidden in the transverse cervical ligament. But you have to be careful. Why do you have to be careful? What is this structure here? The ureter. So the ureter is actually passing underneath the transverse cardinal ligament. So what might happen sometimes by mistake, while they are ligating the arteries, they ligate the ureter or ureter. So the patient will come with anuria, they cannot urinate. Okay, so this is one of a common complication of hysterectomy or removing the uterus. Okay, and you have to remember which one passes under which? The ureter passes, which is water under the bridge. We call it water, urine, under the bridge. We have other visceral pelvic fascia ligaments, one between the symphysis pubis and the cervix. It's called pubocervical, and one between the cervix and the sacrum. It's called the sacrocervical ligament, but they are not as important as the cardinal or the McEnroe ligament. So we said we have 3 categories of ligaments that will support the uterus. Number 1, gubernaculum, ligaments derived from gubernaculum. And number 2, we have the visceral pelvic fascia ligaments, or parametrial ligaments, they call them clinically. Of these parametrial ligaments, the most important is this, the transverse cardinal or cervical ligaments. Why it is important? Not only because it supports the uterine or the uterus, they contain the uterine blood vessels. What passes underneath it, water under the bridge, is actually the ureters. A common complication of hysterectomy, removal of the uterus, is that they might ligate the ureters as well, and the patient will come with anuria or difficulty in urination. Now, the third ligament is a broad ligament. Now, when you read a textbook description of a broad ligament, it's somehow confusing, and each textbook will define it differently. Now, it is very simple concept. You have the peritoneum coming from the anterior abdominal wall onto the bladder, onto the uterus, right? Covering the uterus anteriorly, superiorly, posteriorly, and into the rectum. This is the broad ligament, which is basically like this. If you have, this is the uterus, and this is the peritoneum. So the peritoneum is coming from the anterior abdominal wall onto the bladder, and from the bladder onto the uterus, like this. Okay? So this is the uterus. So when you read above the description of the broad ligament, they're going to say it is a two-layered fold of the peritoneum that extends across the pelvic cavity from the lateral margins of the uterus to the lateral pelvic wall, which is exactly like this. Two-layer fold of the peritoneum, right? Covering the uterus, extends from the lateral walls of the uterus to the lateral pelvic walls, like that, across the pelvic cavity. So as you read later on, they're going to say the lateral surfaces of the uterus are not covered by peritoneum or by broad ligament, which is true. Why? The lateral surface of the uterus is not covered by the broad ligament. And it extends across the pelvic or the pelvis because, yes, it is attached to the lateral pelvic walls. Okay? What it's going to contain, what do you think it will contain? It will contain the uterus, right? It will contain the fallopian tubes, right? Attached to the uterus. But will it cover the fallopian tubes completely?
No.
Why?
There is a space underneath it.
Why?
For the egg, doctor. To pass.
The egg sunny side up will omelette. Huh? For the eggs to be fried or non-fried. Why the fallopian tubes are not covered? حول ولا قوة إلا بالله. Huh?
So we can catch the egg.
Yes, of course. يعني what happens if you cover the fallopian tubes? They will not be able to pick up the ovum. So only 3/4 or 3/4 of the fallopian tube will be covered. That will leave the infundibulum and the fimbriae free so that they can pick up the ovum. Okay? So it's going to cover the uterus, fallopian tube, ovarian ligament, round ligament of the uterus, which is the anterior part of the gubernaculum, or it's called the ligamentum teres, right? It will cover, this is going to fuse with the floor of the pelvis, so it's going to cover anything that goes into the uterus or outside the uterus. Like what? Uterine vessels, parametrial ligaments, uterine veins, uterine artery, lymphatics, nerves to the uterus, everything, all of that is going to be covered by the broad ligament. So when you read about it, it's a two-layer fold of the peritoneum. True? Remember this. Okay? that extends across the pelvic cavity. So this is the broad ligament here. Two-layer fold, anterior to posterior, extends across the pelvic cavity, attached to the lateral or to the attaching the uterus to the lateral pelvic wall. Okay? What is going to cover? It's going to cover the fallopian tube, except the last part, infundibulum and the fibria, and it's going to cover the ovarian ligament. Will it cover the ovaries?
No,
Why?
because you want the
Because you want the eggs or the ova to be able to pop up so that can be picked up by the infundibulum. So initially it was covered, but then it was modified, became germinal epithelium. But the ovarian ligament will be covered. What's on the other side of the ovarian ligament? Anteriorly here is the round ligament of the uterus, the other part of the mesenchyme. Okay? And here we have the uterine blood vessels, we have the lymphatics. All of that will be covered by the broad ligament. Now, when you read about it, the line of attachments of the ovary to the broad ligament, that is called mesovarium. Now, this part between the ovaries, the line of attachment of the ovary to the fallopian tube, it's called mesosalpinx, because clinically we call this the fallopian tube as salpinx. So mesovarium, mesosalpinx, and the rest will be mesometrium. And also we have a fourth part of the broad ligament, which is basically suspending the broad ligament to the lateral pelvic walls. These are called the infundibular ligaments. Infundibular ligaments, they are important. Why? Because they are suspending the broad ligament to the lateral pelvic wall. Not only that, they contain the ovarian blood vessels. They contain the ovarian blood vessels. So parts of the broad ligament, mesovarium, where the ovary is attached to the, not covered by broad ligament, is attached, thin line of attachment of the ovaries to the broad ligament is called mesovarium. Between the ovary and the salpinx, mesosalpinx, and the rest is called the mesometrium. Now, what suspends the broad ligament to the lateral pelvic wall? It's called the infundibulum or the suspensory ligament. Why it is important? Because it contains, no, they contain the ovarian blood vessels. Uterine will be here in the parametrial ligaments, right? So ovarian vessels will be contained within the suspensory ligament. So what are the contents of the broad ligament? Uterine tube, except the last part, okay, fallopian tubes. Ligaments of the gubernaculum, we have the ovarian ligament, and anteriorly here, they're going to the round, going through the inguinal canal to be attached to the labium majus, that is the round ligament of the uterus or the ligamentum teres. Okay, what else we have? We have uterine and ovarian blood vessels, ovarian in suspensory ligament, uterine blood vessels contained within the cardinal ligament or the transverse ligament, okay? And of course, you will have lymphatics, nerves, and all of that. In addition, you will have the ureter, as we saw earlier, passing underneath the uterine blood vessels. And we have a remnant of mesonephric duct, embryonic vestigial or remnants of embryonic structures will be located here or close to the body of the uterus. Don't worry about them because you're not going to see them. These are remnants of mesonephric duct. Okay. Now, this is the normal position of the uterus. Uterus is not standing like this in the pelvis. Why? Simple reason, so that it does not prolapse down. Okay. So it is minsadeh, it is sleeping on the, what is that? This is the bladder, this is the urethra, right? So this is the uterus, that is the vagina here. So the uterus is not standing like this in the pelvic cavity, it's actually bent forward onto the bladder. Not only that, but the uterus is not straight, it is bent on itself, like this. So the position of the uterus is that it is bent on the bladder. We call that the antevirgin because it makes an angle with the vagina. And it is bent on itself. It's called anteflexion. Now, more details, it is like this. Now, this is the vagina. If you have a long axis passing through the vagina and you draw another long axis passing through the cervix from the internal os to the external os, there will be a 90-degree angle between the vagina and the uterus. This is called the antevirgin, vagina virgin, okay? So there's a 90-degree angle between the vagina and the uterus. Why? Because the uterus is bent on the bladder. This 90-degree angle describes the position of the uterus as antevirgin. What is anteflexion? Anteflexion, now, the same axis passing through the cervix, and you draw another axis passing through the external os, the green line, which is basically the body of the uterus, that will create a 135-degree angle between the cervix and the body. This is called the anteflexion. So, in summary, anteflexion is the normal position of the uterus. How do we translate that? Antevirgin, it creates a 90-degree angle with the vagina. Anteflexion, it creates, the cervix create a 135-degree angle with the body. So it is bent forward onto the bladder and it is bent forward on itself. This is the normal position. Now, if these angles become more acute, right? 90 degrees becomes 80 or 70, or 135 becomes 120 or 90, right? These angles become more acute, or they will open up like this, This is the normal position. So if these angles open up, so the uterus goes backward, or it becomes more bent, that is going to interfere with the blood supply to the uterus. That might be one of the causes of abortion, actually, okay? So if the uterus is acutely bent on itself or onto the bladder, or it is opening up the angles, retroverted, retroflexed, that might interfere with the normal blood supply to the uterus. So what is the normal position of the uterus? Anteflexion. Virgin refers to the angle with the vagina. Flexion, it is bent on itself, okay? The cervix with the body create a 135-degree angle. Now, the ovaries, are small structures, 2 by 4 centimeters, located sometimes, some textbooks, they describe them as being located in the ovarian fossa. No such thing, because ovarian fossa refers to the place between the ureter and the internal iliac artery. But the moment that the uterus grows up during pregnancy, they will never come back to their normal position. So 2 by 4 centimeters, attached to the uterus by ovarian ligament, attached to the uterine tube by infundibulum, attached to the broad ligament by mesovarium, the line of attachment of the ovaries to the broad ligament, and we have the suspensory ligaments that contain the ovarian blood vessels. So these are the 4 attachments of the ovaries, okay? ovarian ligament or proper ligament, suspensory ligament containing the ovarian blood vessels, mesovarium, and we have the fimbriae attached to them so that they can pick up the ovum. Of course, they are not covered by broad ligament or by peritoneum so that they can ovulate, okay? Now, vagina is like a tube, okay? And then you have the cervix that will come and invaginate like this into the anterior wall of the vagina. But vagina is basically a tube that extends over 8 to 9 centimeters. Anterior wall is 8 centimeters. Posterior wall is 9 centimeters. Why it is longer? Because it is bent on the bladder, so it is stressed. Okay, by doing this, when you have a tube and then you have the cervix in it, this will create 4 chambers, 4 pouches. Okay, we call them fornices, singular fornix. So you will have one lateral fornix here, one lateral fornix here. We have one posterior fornix and one anterior. Now this is the anterior fornix. This is the posterior fornix. Okay. One lateral will be here, which is like this, and one lateral on the other side. So the vagina surrounding the cervix will create 4 pouches. We call them fornices. Now, sometimes to evacuate fluid from the pouch of Douglas, they go through the posterior fornix. Sometimes people doing illegal abortion, they go with a spatula trying to remove the fetus, and instead of going through the uterus, they go through the posterior fornix. That will cause bleeding and infection and whatever. So these are the fornices of the vagina, created by the invagination of the cervix into the wall of the vagina. Okay, so the vagina, part of it is above the pelvic floor and part of it is below the pelvic floor. So this is the vagina here. What do we have anterior to vagina? You have, this is the urethra, you have the bladder, and the thin fascia separating the two. What do you have posterior to the vagina? Rectum, and then you have the denum villus fascia separating the two. So upper part of the vagina, you have the pouch of Douglas. Middle part, you have the rectum with denum villus fascia separating the two. Lower part is this. What is that? It is perineal body. What is perineal body? It is a fibromuscular structure that will provide support and attachment to the anal canal here and to the vagina. So sometimes during delivery, what's going to happen, if the baby comes big and comes fast, you might end up with rupture of the perineal membrane and you will have a perineal tear that might extend even to the external sphincter of the anal canal. So this is the vagina. Posteriorly, you have the perineal body, and then you have the rectum, and then you have the pouch of Douglas. Anterior to the vagina, you will have the urethra and the bladder. Now, blood supply to all organs in the pelvis will come from what? Internal iliac artery. You still remember this is the common iliac, will divide into the external iliac. External iliac will continue as what? Femoral. Internal iliac, this is the internal iliac. It will divide into 2 branches. You're going to study that in the lab. Basically posterior branch and anterior branch. From the posterior branch, little arteries, iliolumbar, lateral sacral, superior gluteal. And from the anterior branch, you will have the inferior gluteal artery. You will have the pudendal, internal pudendal artery in the pudendal canal. You will have the middle rectal. You will have the uterine or the inferior vesicle. In females, it's called the vaginal artery. And then you will have the uterine. Uterine itself has its own vaginal branch. Okay, then you will have the obturator that goes through the obturator canal, and the umbilical artery, which becomes the superior vesicle. Okay, and then later becomes a ligament, medial umbilical ligament. So these are branches, they are, you know, named here, and you're going to see them in the lab so that you understand them really well. Why I'm talking about the branches of the internal iliac artery? Because it's going to give us two important branches that will supply the uterus and the vagina. Okay? What are these arteries? Number one is the uterine artery. And if you still remember, common iliac, internal iliac, and from the internal iliac, we will have the uterine artery. Uterine artery is going to run where? What do we have here? What do we have here? Uterine artery is running in what?
The lateral cervical.
What do we call that? We just explained this. What is this structure here? Ureter. What is ureter? Is passing underneath what? Water on the bridge. What is the bridge? The transverse cervical ligament or the cardinal ligament or the one of the parametrial ligaments. That's why we said if you were to remove the uterus, you have to ligate the arteries. Once you do that, be careful not to ligate the ureter. So the uterine artery, you will never miss the uterine artery because it is thick and it is tortuous. Okay? It's not straight artery. Why it is thick and tortuous? Why it was not straight? Yeah, imagine if the uterine artery is just a little artery like this, and the uterus during pregnancy goes up to here, to the xiphoid process. So if it was that small, what's going to happen in the uterus? It will be stretched, it will be ruptured. So you fold it and make it thick. So when the uterus expands, it's going to expand with it. You will have room to expand. Okay, so you will never miss the uterine artery. You will see it running in the cardinal ligament, and from there on the lateral wall of the uterus as a thick and tortuous artery. Okay, now we have other arteries from the internal iliac, like the middle rectal, inferior vesical, which is the vaginal arteries. They come and they will supply the and the pudendal artery. They will supply the rest of the uterus, the vagina, and the cervix. Okay, middle rectal, inferior vesical, or the vaginal, and the internal pudendal artery. But also, what supplies the ovaries? We have the ovarian arteries, similar to what? Testicular arteries, or we call them gonadal arteries. They come from the aorta directly, where? Just below the renal arteries at the level of L2, right? So if you take a closer look at the wall of the uterus, it's extremely vascular. So it's going to receive ovarian arteries, it's going to receive uterine arteries, it's going to receive vaginal branches of the uterine artery, it's going to receive vaginal branches coming from the internal iliac and the internal pudendal. It is highly vascular. And you need that blood supply, right? So that's why during delivery you will have severe pain. What kind of pain you will have during delivery? Ischemic pain, right? Uterus is a viscera, is an organ. Organs are supplied by sympathetic and parasympathetic. Organs supplied by sympathetic and parasympathetic or autonomic nervous system, they don't feel pain, touch, and temperature. Even if you burn the organ, the patient will feel nothing. Even if you cut it with knife, patient will feel nothing. The only pain that the patient feels is that of distension. Try to inflate the uterus or inflate the gut or the intestine, or ischemic pain because of accumulation of metabolites. So during delivery, what type of pain we have? We have ischemic pain. So you have the blood vessels sandwiched between the muscle fibers. So when the uterus contracts, it's going to squeeze the blood vessels that are supplying the wall of the uterus. So patient or the uterus will remain for some time without blood supply, so the patient will feel ischemic pain. Okay? So rich blood supply going to the uterus from the uterine artery, vaginal arteries, internal pudendal, and the ovarian arteries. What about venous drainage? You know, uterine venous plexus will drain into the internal iliac vein. Ovarian veins, similar to the gonadal veins. Remember the testicular vein. Remember the pampiniform plexus, where you have collection 12 or 16 or more veins, and then they will be reduced, and you will end up with one gonadal vein. Similarly here, in case of the ovaries, you will have pampiniform plexus will be reduced to one vein. On the left, it's going to drain into the left renal vein, and on the right, it's going to drain into the inferior vena cava. But similarly, remember that, you know, uterine, vesical, vaginal, and rectal venous plexus, they communicate with each other. Now, lymphatics, remember we said, if you don't know, always assume that lymphatics will follow arterial supply. So upper part of the uterus will follow the ovarian blood vessels to the para-aortic lymph nodes. Now, lower part of the body of the uterus and the vagina will follow the uterine arteries and will go to the internal and external lymph nodes. Okay? But we have lymphatics that will follow the round ligament of the uterus to the superficial inguinal lymph nodes. So lymphatics of the uterus, upper part, they follow the ovarian, they go to the para-aortic lymph nodes. Lower part, it goes to the internal lymph nodes following the internal iliac artery. And then we have lymphatics that will follow the round ligament of the uterus or ligamentum teres through the inguinal canal to the superficial inguinal lymph nodes. Now, the final topic of today's lecture is about nerve supply. Now, uterus, similar to the other viscera, will be supplied by autonomic nervous system, sympathetic and parasympathetic. What do? None of my business. Basically, physiologist is going to come and talk about it. But generally speaking, autonomic nervous system will act on three structures. ايش هم؟ Glands, smooth muscles, and
heart.
Cardiac muscles. Okay? So autonomic nervous system will act on three things: heart, cardiac muscle, glands, and smooth muscles. When we say smooth muscles, where do you find smooth muscles? Where? Like what? Give me examples. The gut. But most importantly, the bronchi, whatever, wherever you find smooth. But most importantly, where do you find smooth muscles? And the blood vessels, right? So they constrict or dilate blood vessels. But to me, as anatomist, I'm more concerned about pain and referral of pain. What will carry actually the pain fibers. And generally speaking, when you describe sensation going back from the viscera to the central nervous system so that sensation can be interpreted, fibers taking these sensations from viscera to the central nervous system, they follow, they hitchhike, they go backward along the sympathetic and parasympathetic fibers supplying that organ. For example, now the uterus, the upper part of the uterus, okay, or the intraperitoneal part of the uterus, they say, which is basically down to the, cervix, internal os. they are supplied by sympathetic fibers. Sympathetic fibers, they will come from T11 and T12. So fibers will come from T11 and T12. They go through inferior hypogastric plexus, uterovaginal plexus, whatever. Don't worry about that for now. But they reach the uterus. Okay? What do? They act on muscles, they act on blood vessels. None of my business. Now, when it comes to pain fibers, what they're going to do? Pain fibers, I just said it, they're going to hitchhike, they're going to back, they need access to your central nervous system, brain and spinal cord. How do they reach access? They hitchhike back with the sympathetic and parasympathetic fiber. In this case, upper part of the uterus, pain fibers coming from the upper part of the uterus will go back. And which segments of the spinal cord they will enter? T11 and T12. So if you want to anesthetize, kill pain that is coming from the body of the uterus, you need to inject anesthesia where? T11 and T4. Simple. Right? Now the lower part of the uterus, except the last 2 centimeters of the vagina, are supplied by parasympathetic nerve fibers coming from S2, S2, 3, 4. So if you were to anesthetize, so nerve fibers, we're going to hitchhike or go along the parasympathetic fibers back to the spinal cord. What level? S2, 3, 4. So if you want to anesthetize the lower part of the uterus, including the cervix and the vagina, upper half of the vagina, whatever, you need to put anesthesia where? Into segments S2, 3, 4 of the spinal cord. Right? Simple. Last part, last 2 centimeters of this, of the vagina, are supplied by somatic nerve, not autonomic, somatic nerve, which is called the pudendal nerve. Also, it is coming from S2, 3, 4, but it's not autonomic. Somatic. Somatic means like skin. You feel pain, you feel touch, you feel temperature, you cannot burn your skin, you cannot cut your skin, you will feel pain. Same will happen to the lower part of the vagina, okay? So if you want to anesthetize the upper part of the uterus, which is involved in the first stage of delivery, you need to put anesthesia in the T11 and T12. If you want to anesthetize the lower part, which is in the second stage of delivery, baby is going through the cervix, you need to anesthetize, put anesthesia, what? At the level of S2, 3, 4. Last part, you inject local anesthesia into the pudendal nerve. But how do I put anesthesia into your spinal cord? How do you put anesthesia into make sure that the anesthetic drug reaches your neurons in the spinal cord?
إبرة الظهر.
إبرة الظهر. طيب. So you have 2 types of إبرة الظهر. You have 2 types of injections that you can do. Everything I said is written here, طبعا in the. So either you do spinal injection, needle at the level of L3, L4, just above the waist here, you go to the spinal cord with your injection between the vertebra, you go through the meninges covering the spinal cord, and you reach the subarachnoid where you have the fluid, cerebrospinal fluid, and inject the anesthesia. Anesthetic drug will infiltrate the meninges and will reach the spinal cord. This is called the spinal anesthesia, or إبرة الظهر اللي more well known, epidural. Epidural يعني you don't penetrate the meninges, you remain outside, and then anesthesia will penetrate through the meninges. So the way you enter into the area or epidural area, you have an opening in your sacrum here, sacral hiatus, and you put a tube, until you reach the meninges, and you start filtrating the anesthetic drug. And of course, you tilt the patient backward in a position where you make sure it's going to reach the desired segment, whether T11, T12, or the S2, 3, 4. So basically a tube in your sacrum, you make it reach outside the meninges covering the spinal cord, and you start injecting the anesthesia. But this is too much for you guys. يعني, this is extra information. Main information is that nerve fibers coming from the uterus, they go back, they hitchhike with the sympathetic and parasympathetic fibers. Upper part of the uterus, sympathetic, coming from T11 to T12. So pain fibers will go back to T11, T12. So if you were to anesthetize to make sure that the patient during delivery does not have pain, you need to make sure that anesthetic drug reaches the T11, T12. How? Either spinal anesthesia or epidural anesthesia. Lower part of the uterus, it is parasympathetic. It receives parasympathetic. Okay? We're coming from S2, 3, 4. So nerve fibers, pain fibers will hitchhike and go back to spinal cord segments S2, 3, and 4. Last 2 centimeters of the vagina will be supplied by pudendal nerve, internal pudendal nerve, which is somatic, meaning it will feel pain, touch, and temperature. You can't use cauterization or cut through that area or any kind of procedure unless you anesthetize that area really well. Okay? Any questions?
Yes, sir. There was one question in the chat. They were wondering, this is when you were asking or when you were telling them about how stretching the visceral organs or it causes ischemic pain as well. So they were saying as the baby grows in the uterus, does that cause pain as well as the uterus keeps stretching?
No, but there will be no ischemia.
Exactly.
Ischemia is only caused by contraction of the fibers, and because blood vessels are sandwiched between the fibers of the uterus, so when the uterus contract, that will cause occlusion of blood supply. Otherwise, normally, even if it grows to whatever size, blood supply is still going. So no ischemic pain. Okay? No ischemic pain during pregnancy. No pain during pregnancy. So it's only weight, they feel the weight. Any questions? No? خلاص؟
Yes, sir.
يلا يعطيك العافية. See you next week.